We have a guest in the studio, and let's welcome her. She is Dr. Dorothy Aywak, the Secretary of the Hospital Pharmacist Association of Kenya. We want to have a conversation about antimicrobial resistance. We had a similar conversation last year around November when the world celebrated the World Antimicrobial Resistance Week between the 18th and 24th of November. But it's important to keep harping on this conversation. Daktari, welcome to the Situation Room.
Thank you.
It's good to have you here. Welcome to the hot seat.
Yes, thank you for that.
Sasa wewe ni daktari wa madawa.
Yes. That term, daktari wa madawa, has different meanings, but yes, I'm a pharmacist by profession, and my day-to-day job, I am a pharmacist at the Kenyatta National Hospital, but besides that, I represent the wider hospital pharmacists in the country. We have the association, HOPAK. Yes.
This is the Hospital Pharmacist Association of Kenya. Tell us about it. I mean, why do you have to include the word hospital?
Because pharmacists work in different sectors. You have those in the community, what you're used to duka la dawa, and then you have those in the community, those are the duka la dawa. Then you have regulatory affairs, you have those in industry, in production. Then you have us who work in the hospital sector. So we have different needs. That's why the associations require, we identify with what are the specific needs, and then you build on that. And we basically are existing to be able to promote best standards of practice. And we want these standards regardless of whether you are coming to a public or a private facility. So it's what puts us together.
Okay.
Yes.
The ones in public hospitals, the ones that don't have many of the supplies all the time, what do you call that situation? When you go to the hospital pharmacy and you're told, hii hakuna, itabidi ukanunue, hii ukanunue. Do you advocate for such issues as the HOPAK?
Yes, we try to encourage in terms of having systems to be able to monitor what products that we say, okay, we have what we say the tracer medicines and essential medicines, what you must at least have to deal with 80% of the conditions. And for this, you need to monitor routinely on a daily basis. So we try to encourage our members or even those who to be able to monitor and be able to put systems in place so that you don't wait for when you have run out of medicines to be looking for it. But we also understand that it is not just the pharmacist who will be responsible for having that product. There's also a process around it. Okay. Like for procurement, you need finances available. So you're working with a big team. And we say now there's that lead time, there's that chain, that pipeline that medicine has to get to the hospital. And that's the challenge sometimes. But we find if we keep on routinely monitoring, routinely just, taking initiative to follow up, then now it's and we measure. If we don't measure, of course, we can't know if we are improving. So we encourage even measurements to see that we actually have these products.
For purposes of those who may not have been with us in the previous conversation, just let's start with definitions. When you talk about antimicrobial resistance, what does that mean?
That refers to the ability of a microorganism, that's your bacteria, the fungi, the viruses, to be able to build defenses so that your medicine does not work. So in simple terms, it's just basically the bacteria being more powerful than your medicine. And usually it tends to happen because of the way we use our medicines inappropriately. You don't require an antibiotic or an antiviral, but you use it. You don't, you don't stick to the dosing that has been recommended. Yes.
Okay. Even as you say those words, I mean, even as early as this morning, having conversations and I can understand why it's important to have this conversation, because I think the high percentage of people who self-diagnose and then self-treat over-the-counter medication, because if you go into a pharmacy today and you want to buy a particular drug, unless it's a prescription medication, you're going to be sold that drug. So if I go and I say, well, I'm feeling a certain type of way, and then they're going to give me, I think I need an antibiotic, and I go and ask, and they're going to give me one. So I can hear the importance of having the conversation. But then what exactly are we saying here? If you feel a certain type of way, is its insistence that you must then go see a doctor who will then prescribe, or can you not then self-diagnose and self-medicate?
I want to actually discourage the self-diagnosis and self-medicating because a number of times you probably, like I say, if it's a flu, a flu is viral. So viral infections tend to be self-limiting for a number of them. So when you go and take an antibiotic,
What does self-limiting
or
mean?
self-limiting means it'll just end. It'll run its course, and just you'll get well. So I actually would say if you take an antibiotic when you have a flu, you'll get better in 7 days. But if you don't take, you'll get better in 1 week. But it's just that the feeling that you want to do something. You want to feel you have done something. So people rush to take an antibiotic and they feel a little bit better and they convince themselves that that is what helped them. But you would have gotten better anyway
Okay.
because it would have run its course and then now you'd feel better.
One of the other diseases that I think that we've seen that there's a lot of self-medication on is malaria, or the thought of having malaria. I was rained on, so I must have some malaria. I, sat outside for a couple of hours, so I must have some malaria. What's the prevalence of antimicrobial resistance that we are looking at here? How wide is it? How much of a problem are we dealing with?
Okay. So locally, we don't have very good statistics, but globally, there was a study that looked at what is the extent of the problem. So you find you have about 1.3 million drug-resistant infections that patients are admitted because of drug-resistant infections. Now they're in around 200 countries, that would be 1.3 million. Now the ones which you'd say are responsible for where you can detect antimicrobial resistance as a problem, there would be around 5 million of those. So we say 5 million cases, they are antimicrobial resistant cases. 1.3 million cases are drug resistant pathogens. That's a big number.
So are you essentially saying that folks can be admitted in hospital because there's an ailment for which the drug cannot work?
Yes. Now,
and we're looking at that high number of people?
We're looking at a high number because we are thinking this, what we are doing, the self-medication, they're using medicine when you don't require it. They're not sticking to the treatment regimen, is what is driving resistance. Because what you're doing, it's almost like we are vaccinating the bacteria. We're giving it small doses of the medicine so that they learn how to fight back. And with bacteria, they'll also use the same principle of sharing is caring. So we say the way they transfer that resistant gene, they will help another bacteria to be able to learn how to defend itself from your medicine.
So they work as a community?
Yes. So even for bacteria, it's the same concept. Wow. So I learn how to defend myself from taking this amoxicillin you have purchased over the counter. You didn't require it. So another infection, because we also have routine bacteria in our body. So you get another mild infection, it passes on that gene to help it defend itself from that drug that you're going to take. And now a number of us, probably you've grown up with knowing some certain medicines. You've grown up, I had a generation which grew up with benzyl penicillin. You get a shot of benzyl penicillin before you go to school. So the bacteria learns how to defend itself from the benzyl penicillin. So you come to hospital, the lower levels, we divide them level 1, 2, 3. So you'll hear, you come to a hospital, it has benzyl penicillin, we give you, nothing happens. So you stick around in the hospital or you refer it to a larger facility, give you a shot of something heavier, which is also probably an improvement of that benzyl penicillin, and then it doesn't work because, again, we have taught the bacteria to defend itself.
What are the leading causes of this wrong use of the pharmaceutical products? Is it because the person who is using does not know? Is it that self-medication? Or is it also over prescription? Every time you go to hospital, you're given the same thing. We've seen children go to hospital and they're given the same kind of antibiotic over and over and over again.
Yes, there's actually a blend of a number of factors that influence this increased use. So you have the mother, especially when you're dealing with the mothers or even fathers, generally those who have young children, you'd feel uncomfortable coming to hospital, and then the doctor tells you, just go home and steam the child. And,
and
if you don't live
dawa
with a dawa or an injection, you're not convinced they did anything.
Yeah.
So it has created that perception that if I don't prescribe an antibiotic, then the patient is not going to believe that I've actually done anything for them. So that drives the prescribers to also prescribe the antibiotics. Then there is that, like now, history. You know, I took amoxil and I felt better.
It worked.
So since it worked for me, I come back and just, like, you sort of order the same thing. It's like a meal that you enjoy, so you decide you just order the same thing and hope that it works for you. But you don't realize that you're actually building the defenses system for the bacteria to be able to work against that medicine.
There's this little matter of adherence. Huh? Now, the pharmaceutical industry is a massive industry, huge, big pharma. When it comes, let's start with antibiotics. Huh? When professionals like yourself prescribe medication, you're told 7 days, 5 days. Yet, by the second or third day, you're already feeling better. In fact, so much better. And so the need to continue, these are 3 days or 2 days, doesn't become obvious to you. But it creates a problem you're discussing. The question I want to ask is, this is not now directly related to the association that you are part of, no, but the larger group, yes. Would you say that there's enough effort made to get people to actually understand the need to adhere to whatever it is that they're given? And at your level also, is time taken to explain to the patient what it is that these drugs do, okay? Because even with many medical practitioners, unless you ask,
You'll not be told.
you just told, take this, take this, that. We come to you and you look and you say 1 3 times a day, 1 6 times a day, whatever it is that you indicate.
Before meals with a lot of water.
With a lot of water. And keep in a cool place is already written there.
Yeah.
Yes, but is time taken to explain, even in 2 sentences, look, this particular drug does this. No one is going to take time to read that little piece of paper with
Microscopic.
Yes. The contraindicatives. Is time taken to at least tell the patient about these things?
Well, that I have to admit is actually a challenge in many facilities, because usually you find by the time the patient gets to the pharmacy, it's the last stop. So if depending on which how much time they spend in hospital, they just want to go home. So most of them say, just give me my drugs, I go home. So I admit that is a challenge, and we're trying to work slowly to encourage our teams, our staff, the rest of our members, that take time to explain how to use a particular medicine and why they need for that duration of time. And to answer, when it comes to how you feel better after 2 days, ideally for effective antibiotic, you need to reduce at least 90% of the burden of that. If we say 90% of that bacteria has been reduced, you start feeling a little bit better. You start feeling, but you now need to kill off the rest, because you remember it's been multiplying in your body. So if you think of it like a child, it's at various stages. So if it needs to kill it when it's still a teenager, in the teenage stage of the bacteria, then when you're taking the medicine, you kill most of the teenage and the adult, but the ones which are baby, they are not, are still there. So you continue your treatment so that this one gets to teenage and you kill it off. But now when you stop your treatment very early, now you end up, you're teaching the baby to learn how to build
live
defenses.
with that.
Yes.
Do you know the first bit of your conversation took you 15 seconds to explain. I was timing it. And you explained it beautifully.
Thank you.
The other bit, when you're now elaborating, it took another 15 seconds. It doesn't take
A
that
minute.
long. No, thank you, Eric. It doesn't take
It
a
doesn't
minute.
take a minute.
Yes, and yet you've explained it beautifully. Who cannot understand that explanation that you've given?
I want to hope it is very clear. Yeah. But I know our challenge is learning to communicate to our clients. Unfortunately, soft skills are usually not something that you teach in school or even that they focus on.
There are no units that when you're in pharmacy class, they don't teach you how to...
Soft skills, no.
No.
The focus is usually, so probably unless we devise our training to look at how do you teach to communicate to others.
Right.
Because explaining even how to use other forms of medication tends to be a challenge
Yeah.
to a number of people, and even in a language that the patient can understand.
Sure.
Yes.
Even if before we go to then what's being done in Kenya specifically, even if we don't have the exact numbers, I mean, because clearly looking at this resistance, it's not just a pharmacological problem, neither is it a it's also clearly a social problem. Social one being that, I'm going to stop taking the medicine when I feel better. I'm going to go self-medicate. So there are communication issues, there are social issues. Is that part of now the approach to deal with this clearly, evidently huge problem?
Yes, at least now from last year, probably 2 years back, the Ministry of Health has been engaging the community sector also a lot more. So they've been trying to have forums with them to just be able to get their understanding at their level, at their understanding of how they use medicine, just assessing their practices and talking to them. And even I'm hoping this would be just one of the various ways that we can go about talking to the general public of how their practices, which are actually contributing to antimicrobial resistance. So it is probably now we are talking a lot more about how the community can participate, and we look at that social angle, how they can participate in be able to reduce the pandemic, which is the antimicrobial resistance.
There's the user end. Okay, so you given me some antibiotics I'm supposed to take over 7 days. I stopped before the 7 days because I felt better. Oh, I got to a point where I forgot. Oh, there were just too many drugs and I felt, forget about this story. There's a user side. There's also the user side where you sit, and because of your upbringing and what you're socialized, you self-medicate. You sit, you feel like this, you diagnose yourself, you give yourself a prescription. But then there's the other side. You access the medicine from somebody who's licensed to supply you with medicine. So is there an issue, or is there a conversation that's happening on then looking at how to regulate over-the-counter medication?
Yes.
And how to access over-the-counter medication? Because let's face it, in very many cases, you go to a pharmacy and you
Yes,
say,
you'll get an
I
idea.
want A, B, C, D. They don't ask you, why do you need, what are you feeling? I mean, what's causing you to think that this is what you need? Do you have a prescription you don't have? So there's no question. Uko na nini? Niko na hii iko generic, niko na hii original, niko na hii ingine, unataka gani? There's no discussion.
Kuna hii, kuna hii ya China,
Kuna hii ya
kuna hii ya
India.
India, kuna hii ya Germany.
Unataka gani? And we move on. Is there a conversation on how to have stricter regulations on accessing the medicine?
Yes, now with the Pharmacy and Poisons Board and the Ministry of Health, they are trying to work collaboratively, especially because the challenge is in the community. When you come to hospitals, you are forced to work within a guideline because you see there'd be practices, best practices that you're supposed to adhere to. So it'd be harder to access in a hospital unless it's written for you. But in the community sector where there is no control, we're trying to encourage, when you talk to our fellow pharmacy practitioners, just to also sensitize them and to just let them see what part they play in contributing to the problem. And now, if you tell a patient you need to go back to the hospital, they imagine that queue that they have to go through and to see the doctor, the clinician in that facility. So another strategy is looking at how can we get those in community. Now community is what you'd see as the duka la dawa, the pharmacies that you access easily. If we can get those in the community to be able to link up with another clinician or another hospital facility to be able to have a conversation. Now we have a client who has presented themselves here, they're complaining about this. Chances are they will not want to go to the hospital. But if you can be able to consult your colleagues and find out, do they actually require an antibiotic? And even what would be, when we say we have empiric guidelines, if a person who seems like they could be having a chest infection, what would be the first thing that they can take so that they take according to their guideline? So those are the conversations we want to also encourage having with the community, those practicing within the community, the general. But again, we also appreciate that there are a number of them which are not probably, they may be licensed, or someone might be going to a place that is not licensed.
Yeah.
And you'll notice their pharmacies have become almost like salons. There are so many next.
so
So
many.
you'll
Responding to the need.
You refuse to dispense to one, then
They
they'll
walk to
just
the
go
next
to your
one.
neighbor because you are the difficult person who is refusing. But now if we all speak the same language, it'll be easier for
So,
adherence.
For me, I just feel like the issue then comes to the Pharmacy and Poisons Board. on its role in regulating and licensing and making sure that only licensed pharmacies are in operation. So are we properly adequately resourcing the Pharmacy and Poisons Board? Does it have enough personnel to actually go around and conduct those spot checks and checking?
What is it that determines that a pharmaceutical product can only be consumed when it is prescribed for you or when it is just
Over the counter.
Yes.
Okay, we have the Pharmacy and Poisons Board that does what is called scheduling of medicines. Scheduling is grouping medicines, what is going to be available over the counter. Like now, we'll not expect you to go to a hospital for headache. If you have a headache, they should be able to just assess, or even you present your symptoms over the at a pharmacy and you get the medicine over the counter. But then there are those which require a physician or a medical professional to be able to assess you to actually be sure that you really have symptoms of a disease that requires that prescription medicine. So that scheduling is done by the board so that it guides you that if a patient comes and this is what their complaints, this is what they should use. And now if we, like we say, if you allow to dispense like hypertensive medicine without a prescription, that you just come and say, I feel I have a lot of pressure.
Nikona pressure.
Yes. And you've not been seen. You see now what kind of, maybe you have low blood pressure and we assume ukona pressure is high blood pressure. And then you see, because there are also medicines that we call them high alert in the profession, that the chance of an error, if you take the wrong dose or you didn't require, then the effect could be significant harm, and significant harm means even death. So you don't want to risk a patient just coming for what we'll say a high alert medicine just over the counter. You say, niko na pressure, give me some antihypertensive.
Collins Makasoja says, kindly ask the daktari to highlight some of the signs and symptoms of antimicrobial resistance.
Okay. It's, that's like a concept. It's not, would say if you're given treatment for the duration, you're on a 7-day treatment and you're not getting any better. And we know that, say the patient has tuberculosis. They've been treated for the 6 months or 9 months, depending on what regimen they are on. And you're not seeing any resolution of the symptoms. You're not seeing them getting any better. They're not responding. Then that is antimicrobial resistance. Okay. It's not, we'll not say like you'll have a fever, runny nose, and then you'll say you have antimicrobial. It is that you come for treatment and the treatment, you're not responding to the treatment. So now you've become resistant. Yes.
Okay.
But there's also the concept of tolerance. You keep, but now that one would work more with the other chronic care medicine. You tolerate. You've been on a certain regimen maybe for diabetes. It's no longer working for you. You've learned to tolerate the medicine.
But Daktari, what about just without you having developed any resistance or intolerance, you just react adversely to it? I ask this question because when I worked in the HIV and AIDS field, care and treatment for a long time, and one of the things we saw with ARVs were some people were given ARVs and their reaction was adverse.
Yes. Now that happens actually with this, like any medicine, you can actually react adversely to any medicine because the way we'll say it's your body picks it as something to reject. It picks it as a foreign body that it needs to reject. When you think of when the transplant patients, when you give organ donation, then you will see the doctor will say we have to give them medicine for anti-rejection so that now they can make sure that they preserve that organ. So if we look at the same way, when the medicine that you react to, the body has picked it as something foreign that it needs to fight. So that fighting is what now you start seeing as the adverse drug reaction. And I want to commend the one who keeps a documentation. I think it was Ronnie. Documentation of what he has been prescribed to. It's a very good practice because now if he reacts to one of those medicines, when he goes to a health facility, he can say, I've taken this drug before and this is what happened. But there are those people who probably if you are very good in following your health history or your family health history, then you know maybe you have sibling who reacts to maybe ciprofloxacin. So there's a chance, you don't know whether there's a chance maybe you also have the gene or the traits that will make you react to that medicine.
Sure.
Hiyo ni
So,
dawa ya nini hiyo daktari? Ya minyoo
I
ama
don't
ni-
want no si ya minyoo. Ukihitaji utaenda kwa mtaalamu na
No, please don't go and
atakuandikia.
ask for ciprofloxacin today.
No. I try to look for some medicine that I don't think people will ask for routinely. But there's that would happen a lot. If you'd realize and you'd pick out adverse drug reactions a lot easier when a big population of people are using medicine. So you see now for the ARVs programs, you put a large population of people on treatment. So it's easier to start noticing that there's an adverse drug reaction. It's almost like now with vaccines, people start saying, I think my liver failed after I took the vaccine because we're vaccinating everybody. So something that would take, you'd need to see 1,000 patients to identify. Now you see it a lot more because you are giving the same treatment to a large population.
Does the Pharmacists and Poisons Board have the capacity to determine, man, this is going to be a tall order, that the drugs that they should we say they gave a tick of approval, actually do what those drugs or what is advertised to actually do? Do they have the capacity to determine that?
Yes, they have been doing what is called routine, we call it post-market surveillance. And then also within facilities, you're also encouraged to report when you think there could be that a drug is not working as you expect. So in their routine post-market surveillance, they just go out. If they decide they are looking at antibiotics, buy several different brands of antibiotics, go and test to see if they actually claim. They claim that if it has 100% of the drug, does it actually contain 100% of the drug? Then also they depend on us healthcare workers to be able to report. If you keep on giving a drug, I'm afraid of mentioning a name, and then now you want to decide to describe
Definitely.
it.
Definitely.
So if I give a drug, let's say we call it ericmycin. Yes. So ericmycin, if the healthcare workers decide that they find that there are a lot of their patients, when they put them on this treatment, they are not responding, then now you will report that, and then they will note that we are having several complaints on that. Now that is pharmacovigilance, which is actually the field that I am passionate about. So we encourage healthcare workers, if you notice there's a problem, report. Because now if you don't report, the board has nothing to be able to make decisions with. And then even for the patients to do the same.
This process that you've just mentioned, is it throughout the country?
The surveillance?
Yes.
The surveillance they routinely carried throughout the country. But they
Yes.
could decide to pick a region and they do that region, but most of the time
So they can do so randomly.
They do randomly.
Now, why I'm asking this is, what method of collecting this information does this particular body then have to ensure that the reporting system is uniform throughout the country so that the information you get is something that you could refer to as reliable?
Okay. So what is their system for reporting?
Yeah.
We have there's an electronic reporting system. We call it the PVERS, the Pharmacovigilance Electronic Reporting System. That even somebody, even like yourself, you can actually make the report to the Pharmacy and Poison Board. There's
Have
a
you heard what
simple
I've just been
system.
told?
And hapo useme erythromycin is not working.
So you can actually go and say, yes, erythromycin is not working, or I took this. And so now they even made a simplified. There's a more detailed tool for healthcare workers to log in and be able to make that report. And then there's simple tools for just the general public. And they also have embraced technology. So even if you complain on Twitter, they'll be able to follow up with you because they have a Twitter handle, Facebook. They'll be able to follow up and find out what was this product. And I know we've had a few times when the board would come to a health facility, a patient says they came here, they received
And
this.
there
So
was
you
this.
can be able. So you see, they make that effort.
So that vigilance is possible. I mean, and we're looking at down to the detail to be able to trace an individual and say that this and this. So then why can't we get the numbers then in terms of antimicrobial resistance in the country? Why can't we get and say Kenya as a country is facing a problem and we have X amount over this period of time? For it. If we can be so vigilant in one, How come it's difficult on this side?
Now, the challenge has been especially laboratory capacity. For you to say you're resistant, for them to be able to check that indeed you're resistant to a bacteria, the lab has to be able to give that report. And with many facilities, you might find that their lab capacity is poor. Either they don't have reagents, they don't have the staffing, they don't have the machines, they don't have the personnel, so they cannot be able to routinely monitor. Then also we need our healthcares to be able to use even the lab, that before they treat, they can be able to take the necessary tests so that you can see. You take a sample, take it to the lab so that you see what antibiotic will the patient respond to, then you dose according, or you prescribe according to that that information. So we need to build capacity for our labs. We've had initiatives with different grants now maybe coming in, and then they try to support laboratories, but you find many times it's in the, we'll say like level 5, level 6 facilities, the county referral or the national referral hospitals. And then now you find a number of your people now from the community are going to the lower level where maybe the lab capacity is not there. With a facility which maybe only has one nurse doing everything. So now she will just give you what
she can work with.
Yes, what she can work with.
Are we therefore saying that we don't know for sure whether we have antimicrobial resistance in Kenya?
We know for sure we have antimicrobial
How
resistance.
do we know if we have not tested going into the labs?
We have now, you see, within health facilities, like I say, within the big hospitals, they keep routinely monitoring what we call antimicrobial susceptibility. So they routinely monitor and they notice there's a problem. What we don't have is, like we say, national data. So you will give the data of specific now maybe big hospitals, and then you will want to infer. But what would be good is if we know really in the whole country what is a problem. And if you use the information in Nairobi to guide the people in Kakamega, probably the person in Kakamega is not exposing themselves to the same extent to antibiotics as a person in Nairobi. Or they could be even exposing themselves worse, because we know we also have antibiotics being used irrationally in agriculture. So we may be, the way we treat the person in Nairobi, what they're exposed to is different. So the way when we test them, you'll find that population, they are sensitive to a certain number of drugs. But now, where maybe it's a heavy agricultural community, they are basically bathing in antibiotics as they are treating their fields and the like.
Yeah.
So the way their picture will look different.
Sure.
So at times when you try to use what it is how you manage a patient in maybe Kenyatta, and you say you'll manage that same patient in Meru, they might have the same condition, but it may not work because of the exposure.
Of the exposure.
Exposure.
Are we then also saying, okay, the question, have professionals such as yourselves or the board flagged some category of medicine or some product or some specific brands where you can say we are seeing a high likelihood that there is patients have developed resistance to these particular ones?
Yes. These, okay, we say we have the way we have divided antimicrobial groups according to a WHO classification. We have the access medicines, which now should be available in majority of us. It should be easily available. Then we have the watch. Watch are the ones which tends to have a high likelihood of resistance because of the way we have been using them. Like I would want to hope the marketers of Ceftriaxone will not come.
Look for you.
Yes, I look for. So we have one drug that almost every outpatient setting, if you go to an outpatient setting, you will get that shot. If they think you could have possibility of an infection. But now that has driven the resistance to that molecule. So you have that watch class where now we are supposed to be monitoring, seeing how is the use, and even the board and even the Ministry of Health, they have a local a team, a secretariat that is actually routinely following up and trying to use several approaches, including the...
Can I ask? You see how with vaccinations, you're able to, and then, with proper practice, you're able to eradicate a disease, right? Now, with AMR, are we also saying that it is possible to have,
A disease eradicator medicine.
Yes.
So
So is it possible then to have the opposite happen, that people are using medication in the wrong manner, so much so that this drug then
Becomes
across board
useless.
beams useless
Yes.
wherever you will use it?
Yes.
Oh, okay.
So we're actually turning some of our antibiotics into basically to be useless. I don't want to say to water, but we are basically turning quite a number of antibiotics. And the challenge with the antimicrobial therapy, with the using antibiotics, is that if Eric uses it wrongly, you're together. The same. So there's a chance, you see now, you see you can get an infection by inhalation. So there's a chance he can spread the infection to you.
And then I go
And then
use
now
that
you go use the same medicine. You never used it before, but he has passed to you the bacteria that is already resistant. So it doesn't work for you. Then you go to your house, pass it to whoever you stay with. So now you build that in the community.
You know, Dr. Forgive me, I'm going to take you back. The reason why I asked about the testing capacity, and I thank you for the very robust response, is because I've been reading and I've been updating myself with the news about the opioid
Crisis.
Yes. Now, the drugs were meant to be painkillers, predominantly. Now, how then did it get to a point where you now have people who not only have addiction, but the, again, adverse effects of the drug are profound to the point where you have class action cases. We are now at a point where people are being compensated. Whole communities are being compensated, and it's some serious money. And all along, it is being argued that the pharmaceutical industry knew that their products were addictive. They knew. Now,
And the regulators also must have had a clue.
Eric has actually gotten to the heart of the, because that's where I was heading, because a country like the US where regulation is something else.
Yes.
Okay?
Very strict.
There's this body and there's the other one and there's the cousin of this other one. Now, how did that manage to actually get to where it is? And in a country like that, if it can get to that, Yeah.
It's it'll be worrisome here where the controls are more difficult
well,
to
yes.
enforce.
Well, we have controls, but not quite like
Like the
those other
Americas.
countries, yes.
Well, that is quite a hard say now. Now that's where I feel the seat is very hot. Because you see, when you discover, when you're using medicine, because during the research phase, they should declare all the things that they say would go wrong with using a certain treatment. So if you find it's going to be addictive, you need to make sure that you also declare on that very micro writing that it is that there's a chance of addiction. If you know that if somebody is in the childbearing stage and if they take this medication, it's going to affect the fetus, then you need to be able to declare. And if you didn't know that before, and during the course of when they were releasing the medicine, when it's being used in the public, and as a healthcare worker, you notice you're supposed to be declaring. So our challenge is the reporting. But then again, now when it comes to, when you think about the opioids, see, it's besides dealing with the pain, say it takes you away from it makes you dissociate from the pain and puts you in a happy zone. Now that, I don't know whether you've dealt with any addiction patients. To try and pull somebody out of addiction, they will always look for a clever way of being able to get the medicine. They will find a way of being able to get the medicine. So it's different when you did not declare as a company that, you know, this drug is addictive. But there's also that potential. What makes it addictive? What is that high it gives people that makes it so hard to control? And it puts pressure, maybe even the patient puts pressure on the healthcare worker. And if the healthcare worker is not somebody of integrity or steady, then they also just
Go with it.
Yes, they just go with it. Because even with the same problem with antibiotics, you're afraid that the patient will not believe you're a good doctor. So you prescribe
You
the
just
antibiotic.
give them.
You're afraid they'll go to your competitor next door. So you just sell the antibiotic. So it is that the patient pressure pushes some of this crisis.
Even as you're looking at, because now, I mean, obviously it's a problem, you know, because of, you know, inadequacies here with facility, it's not possible to have a clear footprint of what it is, but it's a problem. How difficult is it to get patients off this resistance? And then what procedures then are put in place to try and get them off? And what are we looking at? Is it just as difficult as, you know, healing a particular ailment or worse?
I almost feel like it's almost as difficult as fighting corruption, but I want to hope it's a bit more doable because you see, it is mindset. If you've grown up knowing that it rains on you and you'll have malaria, it's very difficult to change mindset.
Yes.
So unless you get champions, so we want to encourage, if you have champions now, when you go back home, you will tell the ones who are rained on that it's not malaria, you're just cold. Yeah.
You know, in the 1950s and 60s, there was a drug that women are supposed to use to, should we say, bring some peace when it came to...
Thalidomide.
You knew exactly what I was heading with this. Yes, morning sickness.
Yes.
Now, thalidomide caused malformations like you could never imagine in children. I'm going to get dramatic here. Someone's hand growing from their neck. I mean,
It's quite dramatic, CT.
No, yes, but I'm saying I'm just giving an example of how crazy these things were.
Yeah.
That was the 1950s and 60s.
Yeah.
The outcry came because there was this repeated outcome, and people wondered, but what is causing this malformation in these children? What is it? And it turned out to be the drug.
Yes.
We can't have that same excuse now because in this century and with the advances we have made, remember, I started by asking, is it possible for you to tell your patient,
You'll
just
get better.
take 10
Best
seconds?
use of this.
Yes,
this,
yes,
that,
yes,
and
yes.
the other.
So that they hear. Because people don't read those contraindications. They are not read.
Yes.
Or, again, vigilance. The vigilance story I'm sold to because you look at what is happening elsewhere, not necessarily in your country, the use of that drug in other places, and it gives you a clear indication. But why I worry, away from drugs that human beings are supposed to benefit from, we look at the world of those things that we use to make crops grow better. What are they called?
Pesticides.
Hey, those ones.
Or fertilizer. Which
Yes, yes, yes. Same thing.
Okay.
Okay. And you will find some being used in this country, and they've been banned. Now, there's a body that is charged with determining and doing the sort of due diligence that we spoke of. Does that fall under the purview of the Pharmacy and Poisons Board? Or this one, you don't have to answer. I'm simply saying that if that can happen, and we are already beginning to hear pockets of places where people say, this particular product is not very good for human consumption, and you trace it back, and this is in this country, it's because of the pesticide or whatever it is that they use to supposedly enhance the benefit of this particular product.
Yes, I can attempt to answer that because when it comes to regulation of use of pesticides and basically chemicals in agriculture, before that, the Pharmacy and Poisons Board used to handle that. But now that was taken to Ministry of Agriculture and I think veterinary. So now they probably don't have the same controls to be able to so that has become somebody else's docket and they will not have the same controls. Before with the board, they would be able to check everybody.
Right.
But now their mandate seems to end with human health. But we can't, when you're talking with antibiotic resistance, you can't talk about human health without and dissociate from agriculture and both animal and pesticide.
Precisely.
Because it'll get into your body and then now it'll affect how you respond to regular treatment. So there's what is the One Health approach. It's slowly building, but we are hoping we'll see but One Health brings the crop science people, that's FAO, the Food and Agriculture, the veterinary people and human health, so that they work on strategies together to talk to their different people, their different members. Because now, if you're used to, you want the fat chicken, you are unlikely to buy the chicken when it is skinny and it has been fed on just maize. You'll want to sell the fat chicken to be convinced that it's value for your money. But to get it that fat, someone has realized if they throw some little antibiotic in it
can do the thing.
Actually, and you even have sometimes scenarios where if you know some farmers and they know, okay, you're a pharmacist or you have access to medicine, then they say, okay, even if it's expired, just give me I use it for my
chicken.
My chicken or the like I treat. So you see, there's that we have to talk to everybody and realize that what you do, it's actually affecting. It's a triangle. It's affecting us all. There's I think you had mentioned for vigilance, you said you're okay, so I'm hoping you'll be one of our champions. Even when you talk, you remind people
Go
something.
tell it to the mountains,
Yes.
CT.
Over the hills and
Over
far
the
away.
hills
Far
and
away.
everywhere,
So,
CT.
yes.
You have been sent. Go forth by Dr. Dr. We thank you very much for joining us today, and thank you for the enlightenment on matters of antimicrobial resistance and the safe use or proper use of medicine that has been prescribed to you. Asante sana. Join us again soon.
Thank you.
This is Kenya's biggest conversation, the Situation Room. It continues into the next hour. We've been having a conversation with Dr. Dorothy Aywak. She is a secretary of the Hospital Pharmacist Association of Kenya, talking about antimicrobial resistance.
This is the Situation Room, the only way to start your day.